speaking on the World Menopause and Workplace Day, which is September 6th. And my colleague today is Dr. Meher Nicolwala. Dr. Meher Nicolwala is a doctor who practices in America. I practice in the UK, although I'm currently in Mumbai. So we've connected over different time zones, and we just had a brief discussion, and we've been talking more about the differences in how we practice in different parts of the world. But the problems that women face remain the same, whether they are in India or they are in America or they are in the UK. So this recording has been done on behalf of the World Zoroastrian Medical Organization that was started by Zal Cantinwala, and he's been very keen that we create webinars and do our bit as good Zoroastrian medics to promote health and well-being in the wider community, whether you be Zoroastrian or you're not a Zoroastrian. So thank you for coming on, Mer. Mer, do you want to tell me a little bit about yourself?
I've been trained in family medicine. I recently graduated in San Antonio. I'm currently working as a family physician with a focus of integrative medicine, focusing on treating the body as a whole and incorporating different aspects when it comes to treatment options.
Oh, excellent. Well, Mayor, it's actually, very fortunate that I've got you here speaking, because World Menopause Day, which is marked sometime in October, every year has a theme. And this year, the theme actually is lifestyle medicine, which, incorporates a lot of what you currently do. Every year they have a theme. 2 years ago, it was cardiovascular health. Last year, it was menopause hormone therapy. This year, it is lifestyle and medicine. And I'm sure that incorporates a lot of what you do. So yeah, I'll be really interested to hear what you have to say about that. So we're going to talk about menopause and why there's a menopause and work day, and why this theme has been chosen. So we're going to talk about what is the menopause, what is the pathophysiology, how does it develop, what happens to the body, what biochemical changes, physical changes take place, what signs and symptoms a woman would notice, and how you assess it, how you treat it. And I'd like to say that this wonderful PowerPoint presentation has actually been created by Meher, who is far more technical, I think, than I will ever be. So thank you for that. So, so just to start off with a brief definition, we all know that women's periods will stop at a certain time. This is a natural process. Sometimes you have non-natural causes, in the sense that your periods stop before you would expect them to. The average age of menopause in the Western world of natural menopause would be about 51, 52. But in some women who are smokers, they would have an earlier menopause. In women who've had a hysterectomy, that's removal of the uterus, and their ovaries have been removed, or their ovaries have been removed because they carry a gene mutation that may predispose them to cancer, like the BRCA mutations, then they would have an earlier menopause, or a menopause that is not natural. Certain chemotherapy agents that are given for breast cancer and other cancers, and sometimes because of hormonal changes. But otherwise, what happens is that from the time that a woman is actually a female child is born, there is a natural steady decline of follicles, which is basically the eggs. And the decline is far more steep when you get to the 40s. And then the periods stop. And when somebody is not had any vaginal bleeding for a year, and they're not pregnant and they're about 50, then that marks the end of their reproductive stage. They no longer can have babies. And you can only time it retrospectively, because it's only when there's been 12 consecutive months without a period that you can say that somebody is menopausal. So, as I said, the natural menopause is 12 consecutive months. Mean age is about 51. But there are women who have an earlier menopause, and it's called premature ovarian insufficiency or premature menopause. And the cutoff age is about 40. Before the age of 40, it's considered premature because you would not expect periods to stop at that point. You don't use the term premature menopause necessarily. We use the term insufficiency because in younger patients, sometimes the ovarian activity resumes and they will start having natural periods again, and then they can even fall pregnant. There are a variety of causes for that, some of them genetic, some of them related to their mothers having early menopause, and sometimes we just don't know why this happens. And an early menopause is not premature, it's between 40 to 45. And then there's the term that women use called perimenopause, which is basically the first features of the approaching menopause. Women do not find that their periods just stop one day and then they go for 12 consecutive months without a period and then no period. Usually there's the waxing and waning of hormones. They start getting symptoms, hot flushes, night sweats, sometimes erratic periods. And this stage can last a few years. And why is it important to talk about women and workplace when it comes to menopause? And the reason is we've got a changing population. You know, we are all talking about it in the United Kingdom. I'm pretty sure it's the same in the United States, and actually it's happening in South Asian countries as well, where there's a great increase in people living over 75 years of age. There's a high number, 40% increase nearly in the over 85 years of age. And people say, well, why is the menopause relevant today? What did women do in the olden days? In 1850, the age of menopause was about 45 years because the life expectancy was 45 years. Women did not live that long. And today, women are living in the UK, the approximate age of a woman who has not undergone deprivation would be about 86 years. So if you have menopause about the age of 50, then you're going to live at least 1/3 of your life in the postmenopausal stage. And it is therefore important because women are living longer. And the other thing is that symptoms are affecting women who work. 72% of women workers who had symptoms of menopause said that they didn't feel supported at work. 20% said that their symptoms have actually impacted badly on their work and, detrimented their work. So it is a workplace issue. And in the UK, we've got record numbers of people over 50 years in employment. When I first came to the UK 30 years ago, 31 years ago, the age of retirement was 60. Now the state age for retirement is 67. And women constitute about half the workforce, and a large number of them are women 50 plus. And looking at our own National Health Service, which is our medical service in the United Kingdom, nearly half our staff are 45 plus. That was a British BMA is the British Medical Association report. 60% of our consultants and specialists are over 45 years old. Half our general practitioners are over 45 years old. And 1 in 5 of all the 55 years provides unpaid adult care. And because people are living longer, even the older people are finding that they have to provide care to their relatives, parents who are even older. So the over 65 years are the most rapidly growing group of carers. And we do know that women do a lot more in terms of sacrificing their career to have children, to look after children, to be the caregivers. So they're the ones that take the brunt in terms of going part-time. They take the pain in terms of pay cuts and earning a bit less. And it's a shame that at the age of 50, when their children are growing up or can be independent of them, they find themselves having menopause symptoms, which makes them not able to perform so well in the workforce and question their ability to do paid work outside the house. And it's an equality issue now across the globe. The companies are seeing menopause as an equality issue, just like you give pregnant women rights and their parental rights. And sadly, people have reported that, when it's treated as a joke, you're having one of those moments again. They've been colleagues have been derogatory to other colleagues, saying they're menopausal and making it out as if, well, that is something that is to be, it's a put down, and it should not be seen as such. So I'm going to hand over to Mare now. And Mare, can you talk to us about what is what, as you call it, the pathophysiology? How does the menopause develop and what happens to our body?
Sure, I appreciate it. I just want to say thank you, Dr. Birdi, for kind of uh, showing us the impact menopause has on not only women in general, but the workforce and their daily life. So thank you for bringing attention to it. I'm going to slightly switch gears just a tad bit and talk about the specifics of the mechanism of what happens when we go through menopause. So as Dr. Birdi mentioned, is when we're born, we have a set amount of follicles women are born with. As we age, it goes down in number. When it goes down in number, the hormones that regulate everything in our body changes. So with the less follicles in our body, we have the regulation changing. So a precursor to the regulatory system is the FSH. So that's going to go up, but that's in your hypothalamus, your pituitary gland. But what's happening is your ovaries are not picking up on the connection. So they're not going to respond to the signals of the hormone. So as a result, that is where you're going to get the decrease in the estrogen and progesterone, which are basically the two main hormones that impact the symptoms we experience when we go through menopause.
And can you explain to me what FSH is? What does it stand for?
So FSH is called follicular stimulating hormone. It acts to maturize the ovaries that are to help with basically the reproductive stage for a female.
Correct, correct. So yes, so as the FSH, when the ovaries are in full bloom, as it were, the FSH is quite nice and low because it doesn't have to work very hard. But when the ovaries are sort of winding down and the reproductive ability and the quality of the eggs declines, then the FSH ramps up, doesn't it, trying to whip the ovaries into producing more hormone.
Right.
And Mer, can you tell us something about the symptoms that you see women with and that women commonly complain of?
Right. So the most common symptoms we will see is going to be the hot flashes, memory issues, sleep difficulties, mood. They then discuss about weight changes, how they're having more weight gain and cannot lose that weight. They also get changes in their skin. It's more dry. They get more joint pains. They also have discomfort in their private areas. It's more dry, irritated. And sometimes they can get headaches and breast tenderness.
True, true. And women suffer a lot with this, don't they?
They do, and they suffer in silence.
Yeah,
Um, So it's interesting to know because most people would assume that they would only get symptoms when they hit menopause, which is around 45 to 50, mainly being around 51. In actuality, they can experience some of these symptoms 10 years before they even hit menopause. And not only that, they can even experience these symptoms 3 years after going through that change. So women are actually suffering a lot longer than they truly anticipated.
true. Because so many women have been told, haven't they, Mare?
Mhm.
I've seen women in my practice. I'm sure you've seen women in yours that either they have been told by friends, relatives, or a previous doctor that well, it's only 2 to 3 years, you wait it out, and then they come and they say, well, this has been going on and on. How long am I going to suffer? Do you find that?
It is very common in other family practice for these people to verbalize, and we just not take them as seriously. I think we've noticed there's been a new shift and change in practice, at least where we work, where we try to find solutions sooner when they come to us having these complaints.
Right. And would you say that now women and practitioners, medics are more aware, certainly in family practice, and would you say that practice has changed a little bit?
It is slowly changing to favor women and their symptoms so they don't have to suffer in silence anymore.
That's great. And do you find women are coming forth more and saying that now I know, and they're no longer ready to be dismissed or to be told, they will not go away when somebody seems to be saying that wait it out. Certainly in the UK, we find that women are far more astute and far more aware, far more informed.
You're absolutely correct. Most of our female patients specifically come to us for the management of menopause, and they're very proactive in their health, which is amazing because they notice that it just not only impacts them, but everyone around them. So they do see benefit of getting seen sooner to help manage these symptoms.
Yeah, yeah, I know. Otherwise, I used to sometimes get people saying to me, husbands and their children saying, "Can you give us something to cope with my mom's menopause?" But can you tell us something about the assessment? Because I'm aware that there are differences in how in clinical practice in different parts of the world. So can you tell us a little bit about how you would assess a patient, what blood tests you would do?
Sure. So in our facility, which focuses more on menopause patients, there are a couple of things we look at to determine if someone's in the menopausal stage. One of them is just going to be a clinical analysis. It's basically where you've not had a cycle for 12 months. The other aspect, if you want to get more technical, would be a blood work. So kind of how we mentioned earlier in the pathophysiology stepwise approach, you have your two hormones, the follicular stimulating hormone and the estradiol, which is our version of estrogen. So what happens is as we age, there's going to be a reverse relationship. So the FSH is going to be more, and we regulate that as the number 30 units or higher, and then your estrogen will be low, and that's less than 30. So that is kind of how, if you want to go technical, how we define menopause through blood work. And that's what we do at our facility in the US. UK might be slightly different, so I'm going to let Dr. Birdi discuss how they assess menopause from the UK standpoint.
Well, the British Menopause Society generally, the statement from the British Menopause Society is that you do not need a blood test to diagnose menopause in a woman over 45 with classic symptoms. And certainly if they're 51, 52 with their periods having stopped, but generally women are coming a bit earlier to us now with symptoms. And the general guideline is issued by the Menopause Society. And we've got this body called NICE, National Institute of Health and Care Excellence, and they have endorsed a clinical diagnosis rather than blood work for women 45 plus. The thing with blood tests is that sometimes you do them for younger women, and particularly if they have symptoms and they come under the age of 40, then I think it is essential because you want to diagnose them having an early or premature menopause correctly. The reason being that they, the approach to management can be different. With a woman who's having a natural menopause at 45 plus, it's an option. Taking menopause hormonal therapy, hormone replacement therapy. Some women don't want it, others don't need it, other people can't have it because of certain conditions. But for women under the age of 40, then it is actually a recommendation that they should have menopause hormone therapy, some hormone replacement therapy till the natural age of menopause. And that's to protect their bone health, their cardiovascular health, their cognitive health. And for them, it is important to do a blood test, and a blood test showing a higher level of follicle stimulating hormone with a low level of estradiol seems to be confirmatory of this. Of course, if it's a very young person, then you would want to do other tests like, genetic screening and things, especially if they're in their teens or their 20s. But we're talking about the most common things at the moment. So I'll just take over briefly. And we get this a lot in the UK, and they say that, will a blood test tell me if I'm menopausal? And I'd like to direct people's attention to the diagram at the bottom of the screen. And you can see in the reproductive phase, you get this nice sine wave rhythm. And the upstroke shows the rise of estrogen in the beginning of the cycle. The cycle is called the reproductive cycle because the whole idea of women having this cycle is for reproduction. Women's bodies have evolved for that reason. And the estrogen thickens the lining of the womb because it's preparing it to receive the fertilized egg. And then at the apex of this triangle, you will see that there is ovulation and progesterone is released. And the progesterone is supposed to support the pregnancy till the placenta takes over if there's fertilization. But if that doesn't happen, then nature is quite wonderful, and the progesterone then breaks down that thickened lining of the womb. But what happens in this stage of transition? I said earlier that women's periods don't stop abruptly. Women go through a transition phase. Meher, you said that it can last 7 years and plus, the transition phase. And during that phase, you have fluctuating hormones, and you can see how much they fluctuate. And you can see this is why some women find that sometimes their periods come close together, their periods come further apart before they finally settle down, and you have no periods at all, and they flatline on the right-hand side. So this is why you can see how much they fluctuate even within the same day. And that is why we don't advise routine testing of blood tests to diagnose menopause unless a woman, excuse me, is younger or has got atypical symptoms and you're thinking, is this menopause or is this something else? Will you talk us through the hormone therapy that you offer, Mayor, in the United States and in your facility, and tell us a little bit about it?
Correct. So our facility primarily focuses on hormone therapy. It's one of our specialties. There's multiple versions of hormones. So one is going to be the bioidentical. So that's basically it's basically chemically identical to the body's natural hormone. So you're going to have a safer side effect profile. So you're not going to get you're going to get less side effects. The other version is the non-bioidentical. So it's basically, it does the same thing, but on a molecular structure point of view, it's slightly different. So that's where you kind of get to see more of those side effects. At our facility, we push or we promote more bioidentical just because it's easier to tolerate on the patient and you're not experiencing those extreme side effects. Another interesting thing that we try to educate our patients on is that there's different types of estrogen. So there's 3 types that we look at. So estrone, which is called E1, that's basically found in fat. It's very sensitive to cancers. It's the most inflammatory version of estrogen, and it's the one that's mostly predominant, sometimes seen in those with menopause. That's why when it comes to treatment options, we focus on a more natural lifestyle resource because that way we're decreasing the estrogen levels in our body. The other estrogen we use is estradiol. That is the most active when we are in the reproductive stage. Um, so when we do hormone therapy, it's usually estradiol we supplement patients with. And then estriol, it's another form of estrogen. It's mainly seen during pregnancy, but it's also the least inflammatory. So we do sometimes combine it with the estradiol just so we get the less, you get the estrogen, but it's the less inflammatory version. Um, so we usually have in combination, you can either do E2 by itself, you can combine it with E2 and E3, or you can have all three combined. But as of right now, the only hormone that is not FDA approved right now is E3, which is estriol.
That's interesting because we used to have some oral compounds which contain some estrone, and and as you rightly said, Mayor, it is the one that is most commonly produced within a woman's own body from fat. You see,
Correct.
because the fat and contributes to the development of things like endometrial cancer, cancer of the womb. But what we use in the UK is predominantly for systemic use for treatment of hot flushes or hot flashes, as you call them, and night sweats is the estradiol. We use the estriol in cream, vaginal cream, and that is for women who have got vaginal dryness and symptoms. So it's interesting that you're using all three of them. That shows how different practices in different parts of the world. Um, and you said your facilities, is very it's unique in that you practice integrative medicine, and
Correct.
that is so good. Can you tell me a little bit more about that?
So, from the integrated medicine component, we do focus on natural ways of treating the body to make sure your system is in checks and balances. So you can't have too little of something and you can't have too much of a good thing. So our focus is balance. Um, so for us, we always start off with what can you do naturally to help better yourself. And that's where things like diet, exercise, your sleep, and your exposure to environmental factors come into play because that's something that's very cost friendly for patients. So it doesn't matter where you are in the world, it doesn't matter your socioeconomic status, it's something you can incorporate in some capacity in your daily living.
True. And it's really important because a lot of people think that it's just hormone therapy. And if you get the right hormone therapy, then you are going to be healthy and happy, and your well-being is going to be on top, but it does require effort.
Correct.
Can you tell us more about diet, please?
Sure. So for us, we want to focus on healthy foods like vegetables, healthy fats. The reason being is when you're exposed to processed foods, it messes up the cycle. So you're going to have a production of becoming, or you're going to result in eating more unhealthy things, which is going to make your body not tolerate the regulation of itself properly. But it's also important to know that um, we want to avoid a low fat diet in patients with menopause. The reason being is fat is has cholesterol in it, and cholesterol is a building block for the hormones like estrogen and things like that. So too low of a fat diet can be also not a good thing because you're not naturally producing the estrogen like you should be. Another thing to take into consideration is how if you eat animal products, it's important to understand, are they grass fed or are they hormone injected, because what they eat you eat, and what you eat can metabolize into different hormones, causing the dysregulation of your own body's natural hormone cycle. And same thing with the processed sugars. It causes you to have an imbalance in how you tolerate sugars, how you process them, which then can result in bad fats.
True, true. That is so true. And can you carry on, because this is really fascinating, and tell us about exercise?
Sure, I appreciate it. So the benefits of exercise, it improves glucose and insulin regulation, because ultimately sugar turns into fat, which then is the cholesterol building block of your hormones. So if you eat too much or if you don't exercise enough, that fat is going to produce more of that cholesterol, causing that hormone imbalance. Another thing is cortisol. Cortisol is a stress hormone, but it also plays a huge factor in the regulation of hormones like progesterone and estrogen. So it's going to cause a decrease in your progesterone, causing you to be estrogen dominant, which can give you the symptoms we kind of mentioned earlier. So it's important to have a balanced exercise strategy. So you want to mix with the cardio, you want to do strength training. And the aim is to do at least 150 minutes a week of either moderate intensity or aerobic activity mixed with at least two forms of strength training, just to help balance your sugar management and your cortisol levels.
So that would mean just about 12 minutes a day, wouldn't it? It's not, it's doable, isn't it? It's, even if you have a sedentary job, it's doable.
Correct.
And what about the importance of sleep?
Right. So sleep, we talk about the importance of sleep, but we don't really discuss why it's important. So one of the things sleep does is help regulate what we mentioned earlier, the cortisol production, which is the stress hormone. So that helps us regulate the hormones more, like we mentioned earlier, because if cortisol is not balanced, your estrogen, your progesterone, and your testosterone are not balanced. That way, you're going to get more of the side effects of the mood swings, the irritability, the weight changes. So that's why sleep is reparative, because it helps regulate your cortisol levels. And some things you can use naturally could be melatonin, could be magnesium threonate, which helps also with mood, sleep. That's why it's recommended, if you do use that, use it closer to the nighttime. And then a more natural version is passion flower. Um, and then some other women have access to phosphatidylserine, which kind of blocks the cortisol production at night. That you can find over the counter, at least here in America. The doses range from 200 milligrams to 800 milligrams. You can take at least once nightly. So that's also a natural alternative to help with sleep. And then the stress management kind of goes hand in hand with sleep. And then it's important to realize the environmental exposure of everything. Believe it or not, we do have a lot of chemicals in our products that are estrogen disruptors.
Yes.
And that, I think, needs to have more attention to it, because it's a silent harmful chemical. Because believe it or not, plastics actually contain large amounts of estrone. So do beauty products. And like we mentioned earlier, estrone is the most inflammatory version of estrogen. So it's important to keep that in mind when we use some of the products we do use, because you could
Yes.
be directly increasing the wrong
Yeah.
estrogen.
Yeah, there's a lot of work now being done on what you call endocrine disruptors. But you mentioned botanicals, and can you tell us something about those then?
Correct. So a lot of people we've noticed are trying to go away from traditional medicine.
Mm.
So they want a more natural form of treating their symptoms. And this graph right here kind of shows different natural substitutes, the dosage, and what they're used to treat. So if someone does want alternative measures, they have more resources available for them.
And can you tell us something about hormone therapy? Where does that sit in your practice?
So our practice is a very huge proponent of hormone therapy just because we've seen the impact it has on patients. A lot of the females respond very well to it. And when you talk to them, you actually can see that that the impact it's much more prominent than once was expected. Like they tell me that they feel like a brand new person, and not just them, their partners are feeling very happy, less stressed in the home. They're doing more fun activities. It's impacting the quality of their life, and they've seen an improvement in the quality. The whole point that why we focus on hormone therapy, most particularly the bioidentical version, is because the benefits outweigh the risks. It helps improve the vasomotor symptoms, the genitourinary symptoms quicker. It's a natural process because it's hormones that we ourselves produced when we were in our heyday. It helps manage osteoporosis, aka the bone loss, things like that. It's also important to realize when do you start hormone therapy. So that's very important to take into consideration. Most studies show that they want to see it within the first 10 years of their final menses to get the best impact or best results. It's also important to know that it does have cardiovascular or heart disease protection for it. So if you do early estrogen treatment, you decrease the likelihood of getting plaque formation. And then if you do estrogen treatments later on, you're more likely to get the rupture or the breaking of those plaques, causing you to have acute heart events. So timing also plays a huge role in when we do hormone therapy.
True, true. And now they say that when you talk about vasomotor symptoms, we're talking about hot flushes, night sweats. And the reason that we advocate treatment and early treatment of vasomotor symptoms close to the time of the menopause or the menopause transition when women first present is that they're not so benign as they were first thought to be. They are considered markers of cardiovascular risk. So people who have the most vasomotor symptoms also, these are women who are going to have the most cardiovascular risk. They are women who, the heavier they are, they will have more vasomotor symptoms. Women who have more vasomotor symptoms have poor sleep, and they tend to be the ones that have higher cardiovascular risk. And treating them expeditiously at an earlier stage tends to keep the cardiovascular system healthy. Because how the cardiovascular system responds to estrogen and to hormone therapy close to the time of menopause is very different to how it responds, after 10 years and later on.
Correct.
And can you talk us through some of the risks of hormone therapy?
Sure. So, first we have to see if an individual is an appropriate candidate for hormone therapy before we can start it. So here on this slide, we kind of break it down into high-risk patients where we just don't recommend hormone therapy whatsoever versus some individuals where we recommend it, or if we do recommend it, you have to be closely followed. So the ones that we absolutely say no to when it comes to hormone therapy, it's those who have undiagnosed bleeding in their private area. Usually that's a sign of something more significant that needs to be delved in deeper. Other things could be individuals who have current or recurrent breast cancer history. Other things could be a thrombotic disease or a clotting disease where they throw clots a lot. Others are, so same thing, active stroke, heart issues, and liver disease. Because it's important to realize depending on the delivery of the hormone can also worsen some of these symptoms. For example, oral delivery of medications they go through your liver to get broken down. And anytime it goes through your liver, you're more likely to get the side effects of the hormone. And that can worsen some of these symptoms, like the strokes, like liver disease, things like that. So we try to avoid any of those things from happening. Other things to take into consideration is kind of what we touched upon earlier. It's our BMI, which is our obesity. The reason being is the fat tissues produce their own estrogen, and too much of a good thing can actually harmful to the body in an overall picture. So we're very mindful on those who are more heavy set. If they are more heavy set, we work on them to have them decrease their BMI or their weight um, while we are either on hormone therapy or before they get on hormone therapy. Other things would be abnormal estrogen metabolism. So we have to make sure you are able to break down the estrogen or utilize the estrogen to its benefit. Otherwise, us just giving you the hormone isn't going to do much because you're not getting the best benefit. So we do look at all these factors, and kind of what we mentioned earlier about the dense breast on a mammogram. We have to make sure you don't have the breast cancer history or component when it does come to hormone therapy. So these are just some things we kind of do look at before we say, okay, let's proceed further for hormone therapy.
And what do you use for hormone therapy?
So it depends. So it depends on a lot of aspects. So the first aspect is going to be the method of delivery, whether it be through creams, it could be oral pills, it can be under the tongue where you dissolve, it can be injectables, or it can be what we usually do, pellets. So depending on the method or form of the hormone depends on which hormone we give. We try to avoid oral medications and creams. The reason being is that creams, they get absorbed, but they don't go through the bloodstream. They go through something else, which is kind of similar to the bloodstream, but it's the lymphatic system. So you're not getting the best bioavailability of the hormone. Another reason why we don't like creams is like any other cream you put, like lotion, it rubs off. So you could be indirectly giving that hormone to the person sitting next to you, your pet, things like that. Um, and thirdly, the reason why we don't like to give creams is when we test it, we cannot test it through your blood. We have to test it through your saliva. And that can be a very costly test for most people. Another version is orals. We don't prefer orals except for in the progesterone form, strictly because like we mentioned earlier, anything that you take through your mouth has to be broken down and it goes through the liver. Anything that gets broken down, you're more likely to get the side effects from it. So our whole point is to avoid the side effect profile of medications, and you're getting the best um, benefit from the hormone. So we don't usually like to give like oral estrogen. Other options could be under the tongue. That is something we do promote, but we have to be mindful that if you do choose a sublingual version or under the tongue, you have to have 30 minutes where you don't eat. The reason being is anything under the tongue can have turned into a oral form of the medication if you don't take the necessary precautions. So we're very, very particular in what we offer patients and see what they can and cannot do. The ones that we also like to do is pellet therapy and injection, depending on the hormone. The reason being is for injections, it's usually once a week instead of every single day. So people are more likely to remember that once a week injection instead of taking something twice a day. Another thing is it's in your body longer. So for an injectable, it's usually in your body. It peaks at days 4 to 5, and then around day 7, then you kind of see the effect go down. That's why we also do it weekly. We prefer the pellet version because it's more convenient for patients. So usually for females, it lasts 4 months. And they don't usually have to do routine blood work every single couple of weeks. So it saves patients frequent office visits. Um, but it's also the combination of medications we do. So for progesterone, it's one of the medications we do like to give orally from the
Mm.
point of view that when it does get broken down in your sleep, I mean broken down in your liver, it produces a byproduct that can help you with sleep. And sleep is a huge complaint for a lot of women who are in their menopausal stage. So that's why we like the oral version. We also like to give progesterone because it's a protective for breast tissue. So that's also something we like, why we like to give progesterone. And like we mentioned earlier, we like to do as close to bioidentical than other things. So we don't like to give progestin because that's not a bioidentical version of progesterone. The other hormone we usually use with estrogen is testosterone. Testosterone is seen to help women with osteoporosis. It helps patients with brain health, memory, mood, libido. But like we mentioned earlier, we have to be mindful of how much testosterone we're giving because in our fat cells or in our body, excess testosterone can then be converted back into estrogen. So there has to be a balance of the hormones and how much we give because we don't want to give too little that the patients aren't getting any benefit, but we also don't want to give too much where it can be counterproductive.
Yeah. Well, thank you very much for that, Mer. It's quite fascinating. I'm going to stop sharing in a minute, and I have to say that it's very different from the way I practice in the UK, because in the UK the commonest combination is estrogen gel, and micronized progesterone,
Mhm.
and testosterone is only licensed for hypoactive sexual desire disorder for libido,
Yeah.
and at the moment the guidance states that there is not evidence for the others. So it's really interesting to see how differently women are treated.
Mhm.
But it's been an absolute pleasure and extremely informative to have you join me, and thank you for doing that across the different parts of the world, different continents. And it's just to say again that we're doing this on behalf of the Zoroastrian Medical Organization, and we're doing it for World Menopause and Work Day. It doesn't matter where you live. There can be different practices in different parts of the world, but the main thing is that seek help if you have menopausal symptoms. You mustn't think of leaving your work or thinking that you can't cope, because there are so many options available wherever you are. So I am going to stop recording now, and yep, and yep, there we are. So thank you, Mayor. I've stopped.